you're talking about clinical and ultrasonographic correlation, basically what we're talking about is the patients who have a negative infrainguinal ultrasound but have typical findings. So many of these patients are going to have pelvic congestion syndrome or the chronic pelvic pain. There's a large differential diagnosis of chronic pelvic disorders. And typically what ends up happening is that these ladies get shunted around to various different physicians to try to figure out what they have, and we'll go through that in a moment. But the classic definition is non-cyclical pain that lasts at least 6 months. The incidence of chronic pelvic pain is about 2 to 10% of all gynecologic consultations, and it's about the indication for 20% of all diagnostic laparoscopies. And of those diagnostic laparoscopies that are usually looking for endometriosis or other cystic lesions, 40% of these women are going to have signs of pelvic varices. So what are some of the signs and symptoms that you see with pelvic congestion syndrome? So usually it's the onset after the second and third pregnancies, pelvic bloating not associated with menses, dyspareunia, which I always tell the patients is painful vaginal intercourse, postcoital pain that can last anywhere from minutes or to hours, avoidance of intimacy with your spouse is another big problem, and you have to ask for this because they won't tell you unless you specifically elicit this from the patients. Urinary frequency, a lot of these women get sent to urogynecologists and looking for pelvic floor disorders when actually what they have is these varices that are sitting on their bladder causing inflammation, and they wake up in the middle of the night frequently to go to the bathroom. Mid-epigastric pain that is often associated with peptic ulcer disease, but in a percentage of these women, it's actually nutcracker syndrome, which is compression of the left renal vein by the superior mesenteric artery. Some of the clinical signs that you should automatically elicit you to start thinking about this are vulvar varicosities, either during pregnancy or that persist after pregnancy. Suprapubic varicosities, like that one patient I showed you before. Medial high thigh varicosities that are usually branches of the internal pudendal vein, that's an escape vein. Gluteal fold varices from the inferior gluteal vein. Lateral thigh varices that are actually come from those gluteal fold varices, and I'm going to show you examples of all of those patients. So, diagnosis and treatment request familiarity with the anatomy, specifically with the iliac vein. So typically what you see on the physical exam is just the tip of the iceberg. It's always a lot worse once you start looking for them. So just to quickly go over the anatomy, that's the inferior vena cava, aorta, left common iliac vein. This is the ureter. That's a large ovarian vein. Another thing that you'll often see, and your techs will come to you see this, they see that these collaterals that are coming off of the iliac vein, for those of you who do pelvic ultrasonography, the most common vein that they're seeing are these ascending lumbar veins. So on the right, it becomes your azygous vein. On the left, it becomes your hemiazygous vein. But below the diaphragm, it's called an ascending lumbar vein, and this is a very frequent finding. So this cartoon shows you what the anatomy is, and on the left is an MRI showing a May-Thurner syndrome with an occlusion of the left common iliac vein. Oh, I'm sorry, and also what you see here are these cross-pelvic collaterals that you see coming from the pampiniform plexus, and they typically go over the uterus here. So this diagram also shows you what it looks like that's the uterus, that's the ovary. This is a huge varicose ovarian vein in this patient. So the ovarian vein typically is made up of 3 or 4 veins that emanate from the pelvis, and then about the pelvic brim at around L2, L3, they come together to form one vein. This is something that is not usually taught in medical schools. This is the anatomy of the internal iliac vein, and you really should be familiar with this because once you are, you'll know where some of these escape veins come from. So typically from the veins from the puba, volvus, and labia majora, that comes from the round ligament or obturator vein, also known as the I point or the O point. Inner thigh or posterior vulva are the internal pudendal or ovarian veins. And then the gluteal and posterior medial thigh are gluteal veins, and again, the internal pudendal veins. For those of you who want to read a really good article about these I points, O points, I recommend that you read this article by Katchleck. It was in Phlebology in 2010. Which goes over the O points, the I points, the P points, and the G points. Now this diagram kind of looks at the internal iliac vein, which has 2 branches essentially. It has an anterior and a posterior branch. The anterior branch is where the majority of these veins are. This connection right here from the internal pudendal vein crosses over and it connects to the great saphenous vein at the saphenofemoral junction. So this is the most common presentation that we'll see of these high thigh varices. Also, from the ovarian veins, you can also see the internal iliac, and the obturator is where these I points and O points come from, and so on and so forth. So this is what it looks like venographically. You've got a coil, a balloon occlusion here. This is from Mark Meisner. And what you see here is that this is the internal iliac vein. It goes down here through the obturator vein. You can see a little hook sign here that's connecting to your great saphenous vein. Same thing here, another balloon occlusion venography, also from the internal iliac. Again, there's a connection right here through the inguinal ligament to the great saphenous vein. And then this is another balloon occlusion venography, and then there's a vein emanating here. Laterally, that's your inferior gluteal vein, causing that's a G point sign. So physical examination, this doesn't show very well, but there actually is a vein emanating here from the fold. You actually have to look at these patients. So if you see these posterior thigh veins, look up into the gluteal fold. If you see this vein here, think that this is an escape vein. And then typically what it does is it wraps around the thigh, and it can go all the way down the lateral thigh. And as you can see here, it goes down the posterior lateral thigh, and it goes down into the calf on the lateral side. And then this same patient also had a vulvar varicosity. She actually had 3 pregnancies. Her last one were twins, and then all of these veins popped up after her last pregnancy. That's the patient I showed you before with the suprapubic varicosities. This is the typical high thigh medial vein that you see from the internal pudendal vein. This is very, very medial. These are not from the great saphenous vein, but these are escape veins from a pelvic source. So the diagnostic evaluation, unfortunately, many of these women, as I said, get bounced around. Typically, they'll go see their gynecologist first. Now, a lot of our gynecology friends that do the transvaginal ultrasound, their techs don't put the color box on. If they did, they would see all of these cross-pelvic collaterals going across the uterus, because they're trained to actually look for structural abnormalities in the uterus, like a fibroid or an ovarian pathology. So then they get sent to the gastroenterologist, and then they get an upper endoscopy, they get a lower endoscopy. Everything keeps coming back negative, and then eventually they get sent to a vein specialist. Now, many of them have had a CT scan and an MRI done already, and what I typically tell the patients is, do not bring me the report, because the radiologists miss it, in my experience, at least in my area, about 70% of the time. They're getting better at it, though, I have to say. They're becoming more familiar with it. And then when I review it, it's typically right there. You see the ovarian vein, you see the pelvic varicosities, the reflux, you even see the iliac lesions, but it's just not on the report. So if your patients have had it done, bring them in, take a look at it yourself. Oftentimes the diagnosis is right there in front of your face. If you have the opportunity to have techs that can have an abdominal probe and are good at the pelvic ultrasound, it's very, very sensitive and trained technicians. They'll see the iliac lesions. The ovarian veins take a little bit more training, but if with persistence, you'll see the veins. So typically, this is a transvaginal ultrasound, and again, you see this uterus here, and then when you put the color box on, it just lights up. So when we see our gynecology colleagues and we ask them when they're doing this, this is 90% sensitive for that there's a pelvic problem here. So if you get a transvaginal ultrasound with this on, there's a problem in the pelvis. So this is an MRI, again, with that, and here the white, you can see all these pelvic varicosities and these cross-pelvic collaterals. And then this is a duplex ultrasound from our lab in my office here. And what you see here is this is a large dilated ovarian vein. Typically what you do is you look for the external iliac artery, you look for the psoas muscle, and then you just pan laterally, and the ovarian vein should be right there. This is in a supine position, so if they were to stand, it would probably be bigger. And what the data shows that if you have an ovarian vein of 6 millimeters or larger, that's almost 90% associated with ovarian vein reflux. So then this is another measurement. This is 0.79. So this was a very symptomatic, very dilated. There's reflux in the ovarian vein. And this is a study which basically looked at the correlation of ovarian vein diameter with the presence of pelvic congestion syndrome and lesions that can be treated. And you can see the cutoff point here is 6 centimeters or greater. This is a CAT scan. This was a patient that came to me that had a normal CAT scan from the gastroenterologist. And what you can see here, that the diameter of the renal vein underneath the superior mesenteric artery is less than 3 millimeters. Our diagnostic radiology colleagues will tell you that that's consistent with compression of the left renal vein. There is pre-stenotic dilatation of 9 millimeters, also meets the diagnostic criteria. This lady had a nutcracker syndrome along with pelvic congestion syndrome here. We ended up stenting her, and this is what the CAT scan looked like, and it did well. And then this was the CAT scan that was missed, showing all of these lesions. This is a beautiful MRI here, which shows here all of these cross-pelvic collaterals. It shows compression of the left renal vein here. And also, if you look really, really closely right up here, there's actually a stenosis of the ovarian vein where it attaches to the left renal vein here. So I'm not going to go over all these things because I just beeped, but this is the therapy for it. Yes, thing got tugged there. Nick just tugged me. So venography is the way to go. This is a normal venogram. And then these, you don't need to see all this stuff. So the reason I'm showing you is that patient who had the vulvar varicosities, this was her venogram. We stented her, but you can see here the inferior gluteal vein coming out here. So this can easily be treated either with venography or at the bedside. Actually, you can inject this and get the same results. So I'm going to leave it here. This was our study to show that when you treat these patients, they get better, and that if you leave an iliac lesion and just treat the ovarian veins, they don't get better. That's what our paper basically showed, and 80% of these women have an iliac lesion according to our paper. And then this is Mark Meisner showing some serial fluoroscopic venograms here that you can also treat these either in the fluoro room, but Kathy will tell you can also treat these patients in the office as well. So pelvic congestion syndrome. If you get an infrainguinal duplex that's normal in a patient with typical symptoms, think above the inguinal ligament and look for it, do a thorough examination. If all of that's negative, you missed something. Go back to the beginning, get another history, start over again. Good history and physical exams are the key. Transvaginal ultrasonography, if you can get your gynecology colleagues to turn the box on, that would be really helpful. And then treatment includes all the things that we just talked about. Thank you.